Here, Iron Direct Primary Care, bringing you a lecture on serum testosterone versus salivary testosterone. And this is a big subject of discussion in the medical community, but I'd like to put it here on paper for patients to kind of observe because I do both testing in my practice. So here is my blood work and salivary results. This was taken on the same day after the Memorial Day cookout. Had a great time. A lot of patients came to that. So here is my serum testosterone. That's a blood draw, right? I went in the morning and I got a total testosterone and a free testosterone. Pretty good levels, pretty high. And then I also did salivary testosterone. So Access Laboratory sent me some tubes and I did a 2-point salivary testing. So I filled one tube up with saliva. You got to fill all the way up to the top of the tube. It's a lot of saliva and you don't want to spit in it. You get a bad product that way. Don't want bubbles. My salivary testosterone was 97. So what is this? This is a free testosterone. You can see my free testosterone on the serum blood work was 20.7. So there definitely is a different in measurement range. So even though they're both free testosterones, you're going to get two different numbers. It's a little bit confusing. Total testosterone, salivary does not measure that. But salivary measures a whole bunch of other things. So what's the main difference between these two? Well, there's two big speakers on this. Dr. Pamela Smith, she's a speaker for Access Lab, as is Dr. Mitch Genn. But they have two different opinions on this, and I've spoken to both of them at length. I met Dr. Pamela Smith a couple times at the conferences, anti-aging conferences, and I said, Dr. Smith, what's the difference? I mean, I'm doing both testing here. How can I figure it out? And she's like, you just want to do salivary testing. And she really wouldn't answer the question about serum testing. Obviously, she was a paid representative of Access Laboratory, which is great. She's doing a lot of great speeches for them, and she says the benefits are mostly cost benefit. Obviously, we're going to talk about that later. Cortisol is the only way to measure cortisol is a 4-point salivary cortisol measurement. I didn't do that on myself, but I do that regularly on a lot of patients. It measures a cortisol graph over the entire day. Usually, cortisol comes up in the morning and comes down in the evening. I think you saw mine. My salivary cortisol in the morning was kind of low, kind of sluggish in the morning. I do feel like a slug in the morning. So that's probably why I feel that way. And I do use coffee in the morning. And what does coffee do? There's caffeine in it. Spikes your cortisol. Helps you feel more energetic. The cortisol is energizing, helps you get ready for the day. And so I guess I abuse caffeine for that purpose, to manipulate my cortisol. I did that inadvertently, and I only realized I was doing that until I got this test here showing how I have sluggish cortisol. My DHEA was also kind of low, at less than 0.10, so I was kind of surprised about that. I asked Dr. Mitch again, I was like, what's going on? He was kind of confused about that. I asked Dr. Mike Bomer at Amex Pharmacy, I asked his opinion about that. He thought maybe it's because I'm using so much precursor hormone to create testosterone in the first place. So I was like, well, if I'm using up the precursor hormone to testosterone, why don't I supplement with DHEA? It has no harms. So I have been doing that every day. I've been taking a 10 milligram DHEA. I'm going to retest my levels and see what they're at in a bit. So let's look at a little bit of a video by Dr. Pamela Smith and understand why she says that salivary hormones are the way to go.
So I'd like to do something that's cost effective for the patient.
Cost effective.
If I measure all these hormones by serum, including cortisol, it's around $800 or more,
well,
depending
I get better
on
rates.
Doing salivary testing is less expensive. I'd like to do salivary testing because that's how you should do cortisol.
Yeah.
I also like to do salivary testing because it gives me the bioavailable hormone, how much available for the body to use. I'm going to do salivary testing later on anyway. So if I start with salivary testing, then I can compare apples to apples and not apples to oranges. It works out much better that way. Now, why do I say I'm going to do salivary testing later? If you put the hormone on the skin, it does not show up in the serum. I'm going to say that again because a lot of people do not realize this.
And a lot of people disagree with her on this too.
If you're going to apply the hormone to the skin, it does not show up in serum. And that's how a lot of people get too much estrogen, because people will give more. They look at
So Dr. Michigan disagrees with her on this. I asked him specifically about this because she always says this. He does not agree with her regarding that. Topical applications can be measured in the serum. Maybe they're more accurate salivary wise.
Serum levels, they give more estrogen, the levels don't go up. Is there a clinical trial showing this that's published? No. So my personal practice is in the middle of a clinical trial that we are self-funding to actually publish to show this. And in this trial, we are proving what we've always known. When the hormone's applied transdermally, it does not show up in the serum. How about urine testing? Urine testing is so important. It is great to look at estrogen breakdown and the breakdown of all the other hormones. We need to know their metabolism. But I don't dose off of urine testing because it's not the direct measurement of the hormone. It's looking at the breakdown product. So that's why salivary testing is best. And you will see if people use serum testing that they will end up with estrogen dominance because they're using the wrong modality of testing. How else can the patient have excess estrogen? Impaired elimination. Most of estrogen is eliminated through the liver. Some of it is eliminated through the gut. Lack of exercise is a...
You're going to talk about grains and fiber. So fiber, what does that do? That does bind to estrogen. So it actually binds to a lot of excess hormones. So I actually use that in clinical practice. We use things like calcium D-glucarate to bind to excess hormones. You know, I see estrogen dominance pretty commonly in my practice.
Common reason. So is a diet low in grains and fiber. We have made everybody in the world afraid of gluten, but people seem to have never heard of quinoa and other grains. There are environmental estrogens. Yeah. Yes, I am unfortunately drinking out of one this morning.
Don't do it.
I don't happen to like coffee. I happen to like iced tea. So I should actually take it out of plastic because plastic is an environmental estrogen.
Yeah. Soy is too.
We looked at synthetic hormones.
Soy use.
Remember, they're not the same chemical structure. And these are the most common synthetic estrogens available worldwide. We discussed what natural is. It does help to protect against endothelial dysfunction if the hormones are natural, not synthetic, by increasing endothelial nitric oxide.
Not birth control.
And this is true of the study that was done on estrogen. Looking further at natural estrogen, endothelial nitric oxide synthase is a crucial enzyme involved in the production of nitric oxide in endothelial cells. This study showed that compared to natural estrogen, gene transcription of endothelial nitric oxide synthase was 30 to 50% lower if the patient was on equine estrogens. And the naysayers to natural hormones, I'm not sure what medical journals they're reading, because now it's all over the difference. This is from the very conservative medical journal, Hypertension. Women...
Equine estrogen, not the same thing as bioidentical estrogen. Birth control, not the same thing as bioidentical estrogen. Dr. Pamela Smith is spot on about that. So that's her piece on salivary. Now let's look at another example here comparing serum to salivary. This is a patient of mine, young male. Hypogonadism here. That's what we're seeing. A low testosterone total, low free testosterone, low luteinizing hormone too. So there's something going on here. And then we see that also reflected in the salivary panel. We can see his testosterone, his free testosterone is 45. Well, it's within the reference range. You say, well, this is a young male. The reference range, according to Access Lab, age dependent is 40 to 170. So he's having an elderly male's free testosterone. This is concerning. His DHEA is there, his precursors are there. Everything else seems to be in order. DHT is within order. The estrogens are very low. Very interesting here. We also see a depletion of the estrogen. So there's something going on. at a reproductive level here. You should have some estrogens at some level in the male body. Um, Estrogens are protective as well for males. This is why we have to be careful when using aromatase inhibitors. These are things that we prescribe for high estrogen. We don't want high estrogen in men, obviously. But sometimes that can crush your estrogen too low. Men can get joint pains. They can get cognitive issues, obviously, because estrogen is neuroprotective. Pamela Smith makes the case for this quite often, specifically for females, but it applies to men as well. So we can't crush our estrogen into oblivion either. So let's talk about the cost of this. This is probably the biggest deal. We have a full panel here. You probably saw how many hormones this tested here. Estrogens, progesterone, DHEA, testosterone, DHT, cortisol, melatonin, and some other ones. If we wanted to do all that with serum testing, I mean, the cost would be quite high. We're looking at probably over $200, and you can't even order melatonin, and forget about ordering cortisol. It's useless, and you can't do a 4-point. You'd be at LabCorp all day drawing blood to do cortisol 4 times. Salivary is the only way to do 4-point cortisol testing. So if we want to do a simple sex hormone salivary test tubes, just 2, that's one that I did, it's about $100, plus or minus shipping. If you want to do the 4-point cortisol testing, it's about $150 plus or minus shipping. It's a pretty great deal for all you get there. Just ordering one serum DHT, I saw a patient the other day sent me their lab bill where insurance didn't pay for DHTA. It was $370 just for DHT. I can get DHT ordered if we pay cash for about $30. $30, it adds up if we add on a couple other things. You're looking about $120, $180. That is if you're selecting LCMS. So LCMS is a higher grade analysis of these hormones. It's higher end technology. And when you do the salivary, you get LCMS technology. If we're trying to go cheap on the serum levels, we wouldn't do LCMS. Estrogens, progesterone. If you do LCMS with those, it's pretty expensive. If you order all 3 estrogens, that's already $130. I typically don't do that because the price can get pretty high. I usually will order just an estradiol, not LCMS. Not ideal, but we're trying not to break the bank, and insurance doesn't cover these things anyway. But a budget order, we can get a free and total testosterone LCMS for about $20. Not a bad deal, if you ask me. DHEA, yes, is pretty cheap. Estradiol is maybe like $6 or $5. So we can get it done for about $32 and 80 cents. So great deal. So that's my take on serum testosterone versus salivary testosterone. I think both are fine to order. I think you can measure a topical hormone replacement through serum levels. Maybe it's less accurate. I mean, it's definitely less accurate because we're not measuring everything for that simple purpose. So perhaps ordering the salivary is the most accurate. But the one that people are most familiar with is the serum. People ask, what's your testosterone level at? You generally know that if you're above 800, you're doing pretty well for yourself on a total. A free, above 16 is pretty good. So everyone understands that. Quest Diagnostics has a bit different reference ranges, so each lab is going to have their own reference ranges, what I've found, and you have to base it off of the lab's reference range. I think generally reference ranges are too low. You can see also the wide variability in normal reference ranges, so they have total testosterone reference ranges 264 to 916. Obviously you have to look at the clinical picture. If you have a patient who's 265, they're within the normal reference range, but he's got a big belly, he's fatigued, he's depressed, it's clinically hypogonadism, so you can't base it off a number. Patient within the normal reference range, 45. Are we going to say they're normal? Maybe we should look at some other settings, some precursor hormones, so LH and FSH. Obviously you can't do LH and FSH with a salivary. So kind of important sometimes to measure the precursors for testosterone to see, is this at a different level that this is coming from. this particular patient, it is at a different level. And then further testing is warranted. So all of them have their pluses and minuses here. There's no right answer. It's whatever fits your budget, whatever we're trying to do. Maybe ordering both tests. Pamela Smith's, a lot of people do that. Hope you guys enjoyed this lecture. I put the link in for Dr. Pamela Smith's lectures there. That website's pretty good. Has a nice archive. Those lectures go on about 3 hours. That lady can talk. Wow, she's got a lot to say. I've sat in some of her lectures. It's great material. So definitely follow those links if you're interested in learning more about hormone replacement. This is a great resource, this link here. I'll talk to you all next time.